My patient is a 40-year-old male, auto rickshaw driver by occupation, presented with the anterolateral angulated deformity of the right distal one-third tibia fibula shaft, which was progressive, with a limb shortening of 5 centimeter, with signs of infection and with inability to dorsiflex his ankle, with intact sensation and distal vascularity, currently disabled with difficulty to walk. I would like to keep my differentials for this as a malunited fracture with superimposed infection or an infected non-union. Positive history. The patient had a road traffic accident with an open fracture 1.5 years ago, for which he was managed with debridement and external fixator with fasciotomy. For fasciotomy, 4 months after the surgery, he was skin grafted over the fasciotomy wounds medially and anterolaterally. Then the external fixator was revised after 1 month because of the loosening of the pins, and it was removed 1 month later. Then he was given an above knee cast for 1.5 months, and it was removed after that. And at that time, the patient noticed there was a deformity in the right lower leg, which was progressive in nature. On inspection.
No, subsequent to that, what happened? 1.5 year history you give now. Yes. That cast was removed, then it deformity, then again started with what happened afterwards?
Sir, after the cast was removed, the deformity was progressive in nature, and there was also a sinus which was present at the anterolateral aspect of the deformity, for which there was daily dressing done, and the discharge stopped spontaneously after 1 month.
So for 1 year, what was he doing?
Sir, he was on regular follow-up, and he was on external fixator only, sir, and regular dressing.
You said the fixator was removed after 1 month.
Sir, after 6 months, sir.
Okay.
Means first the fixator was given, 4 months later skin grafting was done, and after 2 months fixator was removed, sir.
So total fixator?
6 months for external fixator was given.
And cast?
Then after fixator removal, 1.5 months cast was given, sir.
Okay. And then nothing.
And then, sir, there was nothing. There was no active intervention. Only one cast. Another above knee cast was given for 1.5 months, sir.
And he was walking on that.
Yes, sir. After the first cast removal, the patient was able to partially bear weight on that limb, sir.
Okay. All right.
Now, first things, you are presenting short case or long case.
Yes.
First things, we should not bore to our
Mic pakdo either.
Hello. Now, when we presenting the short case, what is your diagnosis? Tell me.
Sir, I was not able to reach at a single diagnosis, so I would like to keep my differentials.
Yeah. So, what is your main diagnosis where you are making focus?
Sir, mainly a malunited fracture with superimposed infection or an infected non-union, sir.
Where?
Malunited and non-union. United and non-union. How it can be both? Either it is united or it is non-union.
Sir, there were points in the history and examination which were contributing to either malunion or non-union, so I could not.
No, what is your diagnosis? Malunion, non-union, or malunion with others associated with us, whether infection is there with the other point. That is a one. Second thing, it's the malunited. First thing, tibia.
Yes, sir.
What is other deformities are there?
Sir, inability to dorsiflex his ankle.
I'm asking what are the when we are talking about the deformity. Deformity is one. Tibia is one.
Yes, sir.
Associated with local tibia, whether infection is there.
Yes, sir.
Is there?
Yes, sir.
Infection is there.
Yes, sir.
Second, there is a field scar marking.
Yes, sir.
Where is other deformity? Where?
So the ankle is in a plantar flex position.
No, there is no deformity of ankle.
So what is your diagnosis? It is malunion or non-union? It can be union.
Sir, I would like to go with a
and non-union. How can both exist? Huh?
Sir,
okay, what are your findings? So let's start.
Yes, sir. On inspection, sir, there was an anterolateral angulated deformity in the right distal one-third tibia fibula shaft, and There is wasting of the quadriceps muscle. On palpation, there is
Deformity, inspected deformity. Again, tell me, what are deformities? You
Sir.
are telling about the infection, inspection. What are the deformities? One by one.
sir anterolateral, mainly the anterolateral angulation of the distal 1/3.
How you can say angulation?
So there was
What do you mean by angulation?
so there was deviation of the axis from the
When we
proximal.
comment about the angulation, what do you mean by angulation?
The
So
distal.
when we are talking about angulation or the tilt, that is a part of the X-ray. You cannot talk in the angulate. So what happened here? Deformity.
Sir,
This is a procurvatum deformity? What?
yes, sir. There is a procurvatum deformity with the distal fragment is in varus, sir.
That is correct. Okay. Then one second. Any other deformity? Procurvatum of the tibia.
Procurvatum of the tibia. Yes.
With varus.
With varus.
Second, what about toes?
So there is fan, means the toes are fanned out.
When we talk about any deformity of the tibia, then come to the ankle. Ankle deformity is there. Then we have to see the cavus is there, and then we have to go the clawing or whether the equinus of the hind foot is there. So examine from. Lastly, when you enumerate these, then you come to the shortening part. So 1, 2, 3, 4, 5. Then come to the shortening. Then you come whether the varus, where vulgus. Then come to the associate problem, whether infection is there, whether it's discharge, sinus, whether a contracture. What are this? So you have to one by one in the one inspective portion detail. Huh? Now come to the palpatory finding.
Okay, palpation.
Sir, on palpation, there was no tenderness present at the fracture site of the tibia. There is local warmth present. There is no tenderness present at the fracture site of the tibia. There is no abnormal mobility at the fracture site or loss of any transport. There is no loss of transported movements.
Show me mobility at the fracture.
Yes. ये पैर नहीं लगा.
No. You do varus valgus and then anterior posterior. You catch the tibia proximally from the top. You catch it. Go distal, more distal. No, this left hand. Left hand. Now catch the tibia with your right hand properly. You're catching the ankle. Yeah, that way. Now do varus valgus. See, this is how you catch. Okay, from the top for varus valgus. Is there?
No, sir, I could not appreciate.
Okay, now do anterior posterior. Catch the tibia, don't catch the ankle.
So how you judge he is having a non-union? You use the word.
Sir, because
Yeah, you said non-union and malunion. So what do you think? Is the malunited?
On what ground you use the word non-union? It is a malunited, united, no? Or uniting.
Yes, sir. Because on the basis of the point on the history that there was an evidence of open fracture.
So what history has to do with that? Now you're coming to the physical examination on touch, on palpation. So history has nothing to do. Now what do you find? That the thing is in procurvatum, it is in varus, and there is any abnormal mobility or not. So from history, how you can say there's a non-union or malunion?
There was the history by the patient given was a deformity was progressive since last 6 to 8 months.
So
there
is non-union. No. That is not possible. No. On palpation, you find that there is no mobility in the coronal plane and the sagittal plane, and in the axial plane. So therefore, it is malunited according to your clinical finding. Then
whatever diagnosis you are telling, it should be correlate with your findings. Now there is no sign of the any abnormal movement.
Yes, sir.
Then why you are using word that is on history ground? If you are making that, you are wrong, Dr. Gupta. Now go ahead. Huh?
Sir, on palpation, I could also appreciate the palpable inguinal lymph nodes, sir, which was suggestive of infection. Then, sir, on movements, there is no active movement of the ankle dorsiflexion possible for the patient.
Show.
ये पंजा ऊपर करने का ट्राई करो.
Okay.
So there is contraction present over the muscle, but there is no visible movement.
But is the ankle ankylosed?
No, sir. Passively, I am able to.
How I taught you that
Yes,
day
yes,
to hold.
yes, so
That is
passively,
that stiff ankle, the ankle was not moving. You remember that case of peroneal spastic flat foot with calculable bars? How I told you, hold the talus and the heel. Where is the talus? Somebody show, that day I showed, or all of you forgot. This is not correct. No. What I showed? Miss. But you can't come. Somebody from here. You have to hold the heel and the talus. Hold the heel from back, from posterior side. Now hold the talus. Where is your talus?
yes, sir.
Talus किधर है तुम्हारा?
So
With the left hand. Acha, give me gloves, sir. You are all absent that day, Friday. Who are present? Who are present? Can you know how I showed? And but you are locked. You are landlocked. Happily. Very happy that he can't come out.
The moment you mention non-union and the examiner finds out there is no mobility, you're finished. There's no question. You're gone in this case. Because that is the basics. Either it is a malunion or a non-union. You can't be saying, I'll give a differential of non-union. On what basis will you give? So you need to understand, think very clearly and then talk. Don't talk, it's better, but don't talk things which you will have to answer. Now, how many questions you had to face because you mentioned non-union?
Sir, if we could examine facing the camera, it would be good for our online audience as well. Yes. So the camera is that side. So if you could just, yes.
Okay. So where's your camera?
Camera is that side.
So see, that day I told you that you hold the heel and you hold the ankle. This way. Okay. Now in the other case, that day what happened? The ankle was stiff. It was a peroneal spastic flat foot with a talocalcaneal bar and osteoarthritis. But this was not happening. But this is how you do. So with the left hand, you hold the talus. With the other hand, you hold the heel and not this way. Because see what is happening over here. Where are the movements now? Midfoot. Midfoot means which joint? Metatarsal, metacarpal, you are saying what you are saying. Talonavicular calcaneocuboid is midfoot. Subtalar is below talus. That means talus and calcaneum. That's it. So the midfoot movements are dorsiflexion, plantarflexion, supination, pronation, and adduction and abduction. What is the ankle movement? And that's it. So I'm not going to do this way for the ankle. This is wrong. So see, he has got some movement, is not totally ankylosed. Second factor. Now testing for the, I think I should not go on the camera. See, he has to hold this way. Okay, and see this, nothing is happening. So there's no question of non-union over here. This is united in procurvatum and varus, or anterior angulation and lateral angulation. Very simple. Neurological deficit.
See, when you have already examined the patient earlier fully, and there is no mobility, once you are presenting, it is not that you have asked to see directly and present. When you have already taken the case and you know that is no mobility, there is no question as sir has told, then you have to, when you are presenting the history, you should tell clearly that it is, there is no question of non-union then. That means you are making contradictory
So
statements.
this is malunited. Now, what about the neurological status in the foot? What is happening?
So the sensations over the foot are present.
Hmm.
There is no active dorsiflexion present, but the muscle contraction is present, and plantar flexion also muscle contraction is present.
What about toe movements?
So toe movements are not present, sir.
Why?
Sir, maybe because of the prolonged immobilization, there is stiffness in the joints. Sir.
And
Sir, and there might be also tethering of the tendons at the fracture site, sir.
yeah, so extra-articular tenodesis.
Tenodesis.
That's what I told you. Extra-articular ankylosis of the knee in what? Miss? Extension, that was that case. Friday case. Okay, so this is extra-articular, not ankylosis, but stiffness because of tenodesis. Okay, proceed. You want to ask something? Anybody, sir?
What else? What else are you seeing in this which will decide on your management plan? One was the fracture.
Yes.
Second was the neuro. Third, fourth, fifth. The third thing you mentioned was the lymph nodes,
Infection.
which you should have mentioned at the last, actually. What are the main other things which will decide on your treatment plan out here?
So the skin condition.
Yeah. So what describe the skin condition and how will it change, alter your management?
Sir, we can see two scar marks, which is most probably due to the fasciotomy of 15 centimeter by 5 centimeter on the medial and the anterolateral aspect of the leg. And there is hypo.
You said he had a compound fracture.
Yes, sir.
Then why should he have fasciotomy?
Sir, maybe, sir, there might be a chance of any vascular injury or a.
You said fasciotomy. When is fasciotomy done? For VIC,
Yes,
for
sir,
compartment. So how can he have that when he's got compound fracture? He can't have.
Can you have compartment in a compound fracture?
No.
Yes, you can. You can have it even in a grade 3B open fracture. So you can always argue with the examiner if you feel that something is possible and you don't know how much it was compounding. Was it a grade 1 or a grade 3?
What type of compound fracture you think he had? What type of compound fracture? A, B, C, what? 1, 2, 3?
Yes, sir. According to the history given by the patient, the bone was exposed, sir. So it would be at least a grade 3B injury, sir.
Yeah, so 3B means what? Skin loss.
Skin loss.
So skin loss means what? Either you require to cover. You have to cover.
Yes.
Either by in 3B you have to cover.
Yes, sir.
There's no doubt about that. So either by a rotation flap, cross leg flap, free flap, or skin grafting. Something has to be done.
The skin grafting was performed for the.
Yeah, so compartment syndrome is out of question in a compartment to my mind because compartments are open. That itself is a wrong statement, huh? Okay. Proceed.
You didn't mention anything about the knee.
Sir, the knee range of motion is complete and full, sir. There is no restricted range of motion.
What is shortening? How much of shortening is
Sir, limb shortening of 5 centimeters, sir.
Is it
How you
significant?
measured?
Sir, I measured the total limb length from anterosuperior iliac spine to medial malleus and then segmental length of the femur and the tibia. For the tibia, I measured from the medial joint line to the medial malleus.
So how much is the difference?
Sir, 5 centimeters, sir.
So there's a 5 centimeter shortening, there is angulation which is anterior or procurvatum, and there is a varus. And it is united. And the ankle is not steep. Important. And the toes are steep because of extra-articular tenodesis. This is how it is. And sinus, yes.
Sir, there was a history of sinus with distal since last 6 months.
What is the sinus?
Sir, it is a blind tract with an opening to the external environment, which is lined by granulation tissue, which may later be epithelialized.
When it gets epithelialized, it is called as what? No. Non-healing sinus.
Non-healing.
If the sinus tract gets epithelialized, it is non-healing. If it's got a granulation tissue, the vascularity might come, it might close, provided internally the factors are normal.
So is because of extraarticular tenodesis or is it because of neurodeficit? Does he have a peroneal nerve palsy?
No, sir. The sensations are intact, and while asking the patient to dorsiflex, if I keep my hand on the tibialis anterior, he is able to contract. The muscle contraction is present, sir.
That could be a recovering nerve pulse. Sensations are equal.
Seize movements.
Yes, sir. On both the sides, the sensations are equal.
Are the sensations equal on both the foot?
Yes, sir. On both the foot, the sensations are
Show me
equal.
the toe movements. Passive, how much he can do? Active, passive. आप ये उंगली हिला सकते हैं क्या? कुछ बताइए please. So he's what is he doing? Excuse me. Just see, is he having dorsiflexion? What do you see? No, only plantar flexion. So dorsiflexion is not there. So he might be saying true that it could be having a. Does he have ankle dorsiflexion? Show me. Panja upar karo. Lift the leg up. Doctor, come
Doctor,
here.
lift the leg up.
Come from this.
Yes, sir.
Ask him to dorsiflex. No, ask him to actively dorsiflex.
हाँ,
Panja
पंजा
upar karo.
ये पंजा ऊपर करो.
So he doesn't have that either. So he could be having, as sir says, peroneal palsy. Does he have equinus of the ankle? Dorsiflex, show me. Ankle. No.
So up to neutral.
Up to. ऐसा पंजा ऊपर नहीं ले सकते आप. अच्छा ठीक है. So he could be having peroneal, as you're saying.
Okay. So how would you proceed for management?
Sir, I would like to get the radiographic examination for the patient.
Show.
I would like to get an anteroposterior and lateral view of the entire leg, knee, as well as the ankle, sir.
Okay.
Read the X-ray, doctor.
Read the X-ray.
So there are this is a plain radiograph, anteroposterior and lateral view of the leg, ankle, and the knee joint. In the leg, at the distal 1/3 of the tibia, there is a procurvatum deformity present at the distal 1/3. Tibia.
Now you are reading X-ray. Now you can use word angulation or
Angulation.
tilt. Now what is angulation? And what is tilt? Angulation means you pass a long axis through the fragments, upper fragment, lower fragment, and if they meet on the fracture point, that is called as angulations. And if tilt means the meeting point is away from them. So what is there? Angulation or tilt? Probably angulation.
See the AP. What is the angulation in AP?
Anterior angulation is there. Sir.
Huh?
Please repeat, kariye, sir.
Tilt, if the junction of cross points to meeting away the fracture, then called tilt. And if it is meeting at the fracture point, it's called angulation. Here is probably angulation. If you pass a long axis, that probably meet at the fracture level. So this is the angulation, and which is anterior angulation is there. Now, any other problem in the AP? In AP,
Oh, wait, read
what
the
is-
AP X-ray. AP X-ray, read.
Sir, on the anteroposterior X-ray,
Hmm.
the distal fragment seems to be in varus as compared to the proximal fragment.
Hmm.
There is
But how much is the virus? Can you make out from this what the X-ray is showing virus? How much the virus the patient had on clinical examination? He had or no?
yes, sir.
And here you don't see. Why you don't see?
So maybe there is a rotational component.
Meaning?
Rotation of the distal fragment as
Only the distal fragment has got rotated. What is the problem here in the X-ray? What did I tell you about that knee arthritis case? No, wait. Okay, weight bearing is 1 second. Position of patella and lateral malleoli. What did I say? It should be facing the ceiling at right angles, or both the malleoli should be at the same plane. That's the same thing. Here the X-ray is taken in the X-ray department in complete lateral rotation. So you don't see any lateral angulation over here.
Now, beside any other investigation, would you advise him? Only you advise, one is X-ray.
yes, sir.
You are proceeding for management part.
Yes, sir.
So how would you investigate others?
Sir, I would like to get a CT scan done for the
Why?
patient.
Why you want to go?
First of all, you will get a full length X-ray in AP and lateral standing with the patella facing up and the leg in internal rotation so that both malleoli are at the same level. So you will know what is the what deformity? Mechanical axis deviation in what plane?
in the coronal.
Coronal plane. Do you have a full length X-ray? You don't have. So that is the first thing that you will tell the examiner. I want a full length standing X-ray in coronal plane where the patella will be facing anteriorly. That time you will know what is the coronal plane deformity. Is the knee deformed? Knee is not deformed. Therefore, the is not in the femur. So therefore, it's in the tibia. So according to that, then you will draw a right angle to the plafond and you will draw 87 MPTA and you will see where is the deformity, or you can take the convex cortex lines. This is a convex, this is convex, it's cutting over here. That is the deformity. That is the answer that you have to give to the examiner. You don't have that. So you don't know what it is, right?
No. Proceed for management.
Now, one more thing. Now here the fibula is united.
Yes, sir.
So what will you do? How to know that there is a not a delayed union or fibrous non-union as a fracture site? Fibula is united, so it's not moving. So what will you do? You take stress X-rays. So you'll know what is the movement over there. If it's not agreed, then the tibia also could be united. But you'll take stress X-rays in coronal plane. That is the second answer that you have to give.
Now,
Any other?
Bola, Khandelwal sir.
I'm asking, how would you proceed for management?
What is the tibia length from the knee to the fracture site and fracture site to the ankle? How much it is?
Sir, the
Here, because of the deformity, it is short. But is it short actually?
Sir, on the means of the deformity, sir, there was no discrepancy, sir. There was 1 centimeter lengthening actually, sir. When
How can it be
from
lengthened?
from the medial joint line to the apex of the deformity and apex of the deformity to the lateral.
So what is the leg length discrepancy between the two legs?
Sir,
Total was because of varus,
Yes.
because it is gone that way.
Yes.
So it's a triangle. The hypotenuse you are seeing.
Yes.
Now what is the length of the segment proximal and distal to the tibia by measurement?
Sir, by measurement, there was no difference as compared to the unaffected sites.
So therefore there is no shortening. One more thing, why there is no shortening on X-ray? I know that. Miss. No, you. You are landlocked. I call you landlocked today. Tell me. Fibula is united. It's not shortened. If the fibula is shortened, it is short. See, the fibula is malunited at site. So all these things you know on X-ray.
What is the principles of management? I don't want to know
Yes.
what you will do with this. Any other investigations? Quickly tell any other investigations. You said about CT. CT, what would you do?
Sir,
Why you want CT?
Why CT?
Sir,
Why CT you want?
Sir, to see the union status of the tibia, sir.
To confirm your diagnosis.
Confirm the diagnosis and to see whether the medullary canal is potent, means is
Open.
open or not.
See, doctor, first things, you are advising CT. You may be advised, but I may not advise. So it is a controversial thing. Just tell which is universal, acceptable to all. Okay. CT will not give any better informations. You go ahead with the X-ray and blood investigation
Yes, sir. I would
and
like-
proceed for the management part.
Okay, what is
How
the
would- Listen, sir.
management?
How would you go for management part? That is, I'm asking repeatedly. I'm asking.
So my principles of management.
You don't try to teach. Your principle may be differ. My question is this. My question I'm asking, how would you proceed for the treatment? Do not
Treatment.
try to make your question and reply to yourself.
Treatment. Come on.
Now, how would you proceed for the management in this case particularly? I'm asking.
So we have also put the scanogram just for your reference for this patient.
Huh?
We have put the scanogram.
Ah.
Yeah.
Yeah.
Why you want to treat him?
Acha.
Yeah.
Why you want to treat him first of all?
Now look at that.
Leave him alone, na? Why you want to treat him?
So there is axis deviation.
That is okay. Yeah. There is a deviation. But there is united. Why you want to treat him? Why you want to treat him?
So
A simple question.
So because there is limb shortening and axis deviation, he is having difficulty to walk, sir. So
He's giving you the solution out there. So look
Yes,
at that
yes.
and tell me why you want to treat him.
Now you see the virus there.
Yes.
Here.
Yes.
Now how you want to treat fast because we have to take other cases.
Yes.
Sir, I would like to first tackle the infection.
Where is the infection? There is no sinus.
So there was local warmth present and the inguinal lymph nodes were palpated.
Okay, so how are you going into that? Now again you will delay his treatment.
So then I would like to do the deformity correction by doing the osteotomy at the
Sir, I am just observing.
बोलो ना.
It is necessary before going for any corrective steps, you have to rule out infection. And it is important investigation. Without rule out any infection, you cannot proceed for any corrections. Okay? You have to do the blood investigation, CRP, rate, whatever the things is there. And how would you proceed for correction? What type of the procedure you use for correction of the deformity?
Sir, in the blood investigation, I'll get.
All right, blood investigation, there is no infection.
You have done all that. No infection.
No
Proceed,
infection.
proceed.
Now proceed for the deformity correction. Now, how would you proceed for deformity correction?
So for deformity correction, I would first like to calculate the center of rotation.
Okay,
Yes,
okay,
sir.
okay, calculate कर दिया वगैरह सब कुछ किया पर proceed करो पहले क्या करोगे? What you will do first?
Sir, I'll do the first. I'll first do the osteotomy at the deformity site and then gradually correct.
No, I have not understood. What is your plan?
Sir, the
Plan is correction deformity. How will you stabilize?
So stabilize with an external ring fixator.
So that's you know.
Yes.
But tell the others now. My plan could be plating. My plan could be nailing.
So what you want to do,
Plan could be a
Elizaro?
plaster application.
Okay,
So you are going for correction of the deformity. So first you will go correct the angulation, tibia.
Yes, sir.
Very good. You will fail.
Fibula.
First is the fibular osteotomy is the first steps. Okay. Second, you will go for the
Fibula.
Now there is a osteotomy is there required. Now what type of osteotomy you will do? Close wedge, open wedge. What you will want to go? There is a sorting.
Sir, a lateral closing wedge osteotomy.
Lateral closing wedge osteotomy. I'm not understanding. What is the question? Is close wedge or open wedge? You already shortening is there.
Sir, opening wedge osteotomy, sir.
No. So how you will go for open wedge?
You are going to do, excuse me now, you are going to do a Elizaro fixator.
Yes.
Now, after doing that osteotomy of the fibula, what is the next step? Now
So-
we go for Elizaro, you
Yes, sir.
said.
Yes, sir.
Now, how will you know where to put the hinge? Because it is coronal plane deformity and sagittal plane deformity. That means the deformity is in two planes. So therefore, it will be in, where will you put the hinge? That is most important.
Sir,
You will correct both the sagittal plane deformity and the coronal plane deformity by putting the hinge. So what is the next step? You have what is known as the 6-axis type of fixator nowadays, where you can collect all the deformities with that, with turning that what Mangal Pariyar does.
Taylor's
So 6-axis. But during the other times, they used to draw on the graph paper. This is a deformity in the coronal plane. This is a deformity axial plane. Then you find the hypotenuse of that diagram, and one hinge will be here and one hinge will be here, and that is how they'll start. So that is the thing that you must say. But you can go for 6-axis. That is a new thing where you can correct both the deformities. Now you are saying close wedge, open wedge, and all that. Again, in Elizaro, this is not correct. Why? Because it is corticotomy. Once you do a fibula osteotomy, you have to do a corticotomy of the tibia, and by turning that, you will you will open. Then the next thing that you will do is compression. Compression. So what Elizaro said, the infection will burn in the heat of compression and distraction. That's what he said. So then you will compress and then you will distract. What Khandelwal sir said, 1 centimeter, one sec, let me complete. 1 centimeter of lengthening you can achieve by compression and by distraction. That is what I would do in this case, because you said Elizaro.
Yes.
You can't say open wedge, close wedge in Elizaro, because it's a gradual thing that is happening. And with the skin condition that he has, there's no question of doing any implant over there. Khandelwal sir.
Why don't you do internal fixation in this patient? Very simple.
So because of the infection, I would not do an internal fixation.
Very good.
And then it is an invasive surgery if you do internal fixation, and even you can correct the deformity at the same time with the Elizaro
Yes, sir.
slowly.
No.
So correct the deformity and limb length, both I can achieve.
Limb length you will achieve because as you said, it is hardly, it's almost same.
And one thing is, if you are going for any plating or internal fixation because the posterior structures are tight. So you may not be able to correct on table. So instead of going for plate, ring fixator with gradually you can correct later on. So you have to do the, just optimize the fracture sites and gradually you can achieve corrections. That's the best method here. Nothing else. So as far as the sir was telling about the compression or destruction, that is the second part of the management, because here the correction of deformity is the first steps. Second part is a union. Third part, restoration of the length, for you have to go for the corticotomy and limb length. That is the second part of the treatment, which we are not asking you. We are just limited for the treatment part, that is a correction of the deformity. Here, the treatment is the correction of the deformity. You should be limited to over the 1 point. Never go for without asking.
Other than Ilizarov, is there any other technique you can use for correction? Ilizarov is there, but he says, I don't want that, those rings and, things are moving around. I'll go for some other alternative. Is there any other alternative to Ilizarov?
Sir, a limb reconstruction system can be used.
What is it commonly known as? Limb reconstruction, LRS.
LRS.
Can you use an LRS in this patient?
So because it is a multiplanar deformity, LRS would be a less preferable option than Ilizarov thing.
Yes, maybe.
Yes, sir.
So,
Yes, Dr. Agarwal is telling, there may few people may accept, but Ilizarov will accept by the most of the people. So I suggest you, instead of going for the one plane, multiplanar fixations is always superior than the uniplanar fixation. So always say multiplanar will be better because you can handle the multiple deformity on the one times. Okay.
So we'll move ahead with the next case.
Next
or the
case.
next
Yes.
So
time.
may I ask a doubt?
Yes.
Sir, in this case, if there is a progressive deformity, because the patient said the deformity was progressive, so can it be a fibrous non-union?
See, at the moment, this fibrillized united is difficult to say because it is preventing the instability at the fracture site.
Yes, sir, there are no
So therefore, I say that you can take a stress view and see whether there is any instability at the fracture site. That will tell you whether it's a bony union or it's a fibrous union. Second, you said that you want to do a CT. The CT will be diagnostic, whether you have fibrous non-union or a delayed union or you have bony contact. These two things I would answer.
Thank you, sir.
Anything somebody wants to say?
And just one point, I think in the exam, we should not be giving non-union and malunion together for any case. On clinical examination, when you're assessing a patient for the first time, it's very unlikely that your mind will say it is non-union oblique malunion. It has to be either one. You go on your clinical findings, there's a possibility that the X-ray may show something else, but don't get biased by that. Whatever findings you have as a malunion, you present it to that.
Doctor, and first the important things, you should limit it when you are presenting the short case. Diagnosis, that means a malunion and associated problems. Here was the associated problem was the infection, whether the neurological problem was there, that should be. But you have not told you there was maybe some neurologic problem because he was not able to dorsiflex. And you should say some underlying infection with malunion is there. Please.
Was there sensory loss on the dorsum of the foot?
So there was no sensory loss.
So mostly it looks like a tenodesis then.
Thank you,
Okay, this
Dr. Rajan.
lady-
Yeah.